So picture this. A patient walks into your clinic with a completely normal BMI.
Oh, sounds like a healthy patient.
Right, on paper. But their visceral adipose tissue is secretly engineering this massive cytokine storm that's, you know, going to destroy their liver in like 5 years.
Oh, wow. Yeah, welcome to the invisible world of metabolic syndrome.
Exactly. And if you are preparing for your medical boards, you already know the stakes here. The days of simple binary diagnoses are totally over.
They really are. You can't just look at weight anymore.
No, you can't. So our mission for this deep dive is taking our sources and tracking the exact pathophysiological cascade of this syndrome.
Right, we're going to follow a single rogue-free fatty acid from a visceral endocyte all the way to systemic organ failure.
It's going to be intense. But to recognize that cascade in a board vignette, we kind of need to look at the foundational blueprint first.
Definitely. You really have to master the National Cholesterol Education Program, Adult Treatment Panel through Guidelines, or NCEP ATP3 for short.
Right, because they use that strict 3 out of 5 rule for diagnosis. So let's run a quick rapid-fire review. What are those 5 criteria?
Okay, so first you were looking for a waist circumference greater than 102 centimeters for men or 88 centimeters for women.
Got it.
Then fasting triglycerides at or above 150 milligrams per deciliter. Low HDL cholesterol, so less than 40 for men and less than 50 for women.
Right.
Blood pressure greater than or equal to 130/85. And finally, a fasting plasma glucose at or above 100.
Okay, let's unpack this. Setting those rigid cutoffs raises an immediate clinical question, right? Especially regarding that first criterion.
Waist circumference.
Yeah. Why rely so heavily on waist circumference when we have BMI? Like if a vignette presents a patient with a BMI of 32, the instinct is just to assume metabolic dysfunction.
And that instinct is a classic board trap. I mean, BMI is mathematically blind to fat distribution.
Right, it's just a ratio of height and weight.
Exactly.
Right.
It calculates mass without distinguishing between subcutaneous fat, which is relatively safe in visceral adipose tissue.
Which is definitely not safe.
No, not at all. In metabolic syndrome, visceral fat is the actual engine of the pathology.
Right.
And we see this epidemiological reality in Asian and Asian Indian populations. They have a genetic propensity to store fat viscerally.
Oh, right. So that actually lowers the waist circumference thresholds for them, right?
Yes, down to 90 centimeters for men and 80 for women. So a patient can have a completely normal BMI, but still have profound metabolic derangement.
Because their fat is packed deep inside the abdomen. It's basically draining directly into the hepatic portal system.
Exactly.
So visceral fat isn't just some passive storage warehouse. It operates more like an unregulated, highly lipolytic, toxic factory.
That's a great analogy.
Right. Because of its location, it breaks down stored triglycerides into free fatty acids, FFAs, and just dumps that chemical runoff straight into the portal vein.
And that massive flux of FFAs flooding the liver is the inciting event for systemic insulin resistance.
The liver just gets overwhelmed.
Yeah, it responds to this lipid overload by ramping up gluconeogenesis and VLDL production. But the damage extends far beyond the liver.
Because those free fatty acids spill into the systemic circulation, right?
Right, and they directly infiltrate skeletal muscle.
Okay, this is where we really need to lock down the cellular mechanism for the boards.
Definitely a high-yield area.
So we know insulin usually binds to its receptor on the muscle cell to trigger GLUT4 translocation. How exactly do free fatty acids jam that lock?
Well, the circulating FFAs enter the muscle cell and accumulate as intracellular lipid metabolites, things like diacylglycerol and ceramides.
Okay, diacylglycerol and ceramide.
Right, and these metabolites activate novel protein kinase C isoforms.
Uh-oh. Kinase activation.
Exactly. That kinase activation causes serine phosphorylation of insulin receptor substrate 1, or IRS1.
Wait, normally insulin signaling relies on tyrosine phosphorylation of IRS1, doesn't it?
Correct. By switching it to serine phosphorylation, the free fatty acids effectively sever the intracellular signaling cascade.
Wow. So the insulin receptor is bound, but the signal just never reaches the GLUT4 vesicle.
Exactly. Glucose cannot enter the muscle cell.
That's incredible. And compounding this, insulin physiologically acts to inhibit lipolysis in adipose tissue, right?
Yeah, it's actually the most sensitive pathway of insulin action.
So when systemic resistance develops, that inhibition just fails.
Completely fails. Lipolysis goes unchecked, flooding the system with even more free fatty acids.
Which just accelerates the IRS-1 blockade. It's a vicious cycle.
It really is.
But beyond lipid metabolism, we have to look at the immunology of this expanding visceral fat mass.
Right, because adipose tissue is highly active endocrine tissue.
Yeah, and as it undergoes hypertrophy, it becomes heavily infiltrated with macrophages.
And those expanded adipocytes, along with the macrophages, they begin producing an overwhelming volume of pro-inflammatory cytokines.
We're talking interleukins 1, 6, and 18, right?
Yes, and critically, tumor necrosis factor alpha.
Okay, TNF-alpha. Now, TNF-alpha operates through a similar mechanism to those lipid metabolites, doesn't it?
It does. It further promotes that pathological serine phosphorylation of IRS-1.
Driving even more insulin resistance.
Exactly. It acts as a massive accelerator.
Yeah.
And at the exact same time, these pro-inflammatory cytokines are surging, the production of adiponectin just crashes.
Here's where it gets really interesting, because adiponectin acts as this sort of understaffed cellular peacekeeper in a healthy state.
That's a good way to put it.
It regulates lipid traffic, directing FFAs into the mitochondria for beta oxidation, and it enhances hepatic insulin sensitivity.
Right.
But if adiponectin is the good guy, does the body just stop making it as fat mass expands?
Well, yeah. As the visceral fat expands and becomes hypoxic, the gene expression profile shifts. The tissue actively downregulates adiponectin production.
Oh, man. So the traffic cop is removed right when the FFA traffic is at its absolute highest.
Exactly. And the downstream consequences of the cytokine storm manifest heavily in the vasculature.
How so?
The visceral fat upregulates production of plasminogen activator inhibitor 1, or PAIN. And at the same time, the liver produces excess fibrinogen.
Oh, that immediately tips the patient into a prothrombotic state.
Yes. The fibrinolytic system is suppressed by PAI1.
Meaning the blood is highly prone to clotting, which totally explains the astronomical cardiovascular risk.
Absolutely. And the underlying thread connecting all of this, the lipid accumulation, the inflammation, the insulin resistance, is the oxidative stress hypothesis.
Right. The mitochondria just burn out.
Basically. In these patients, we see a fundamental defect in mitochondrial oxidative phosphorylation. The mitochondria simply cannot oxidize the massive influx of fuel.
And that leads to the toxic accumulation of lipid intermediates in skeletal muscle, the liver, and the beta cells of the pancreas.
Which directly drives beta cell apoptosis and the progression to frank type 2 diabetes.
So if you are staring at a board question asking for the classic cytokine profile in metabolic syndrome, you need to look for elevated TNF-alpha and decreased adiponectin.
That is the fundamental imbalance.
So now that we know this inflammatory, insulin-resistant storm is raging throughout the body, let's trace how it manifests in specific end organs.
Good idea. Because the boards will rarely ask about metabolic syndrome in isolation. They will present it disguised as its comorbidities.
Right. Starting with the liver, which takes the initial brunt of that portal FFA flux.
And this manifests as metabolic-associated fatty liver disease, or MAFLD.
Which affects up to 65% of these patients.
Yeah, it's huge. The liver's beta oxidation pathways are just overwhelmed by the free fatty acids.
Forcing the hepatocytes to esterify them into triglycerides for storage.
But that intrahepatic lipid accumulation is just the first hit. The second hit is the oxidative stress and the TNF-alpha we just discussed.
Oh, right, which drives the progression from simple steatosis to MASH metabolic dysfunction-associated steatohepatitis.
Exactly. And the ongoing inflammation activates hepatic stellate cells, leading to fibrosis and ultimately cirrhosis.
It's terrifying. Another incredibly high-yield board association is polycystic ovary syndrome.
PCOS.
We see significant insulin resistance in up to 80% of PCOS cases. But how exactly does systemic hyperinsulinemia drive the classic presentation of anovulation and hirsutism?
Well, the mechanism is twofold. First, the compensatory hyperinsulinemia directly suppresses the liver's production of sex hormone-binding globulin, or SHBG.
Which drastically increases the amount of free active testosterone floating around in the circulation.
Right. And second, insulin acts synergistically with luteinizing hormone to directly stimulate the ovarian, the Seca cells.
Driving them to produce even more excess androgens.
Exactly. Now, we also need to factor in obstructive sleep apnea.
Wait, isn't sleep apnea just caused by physical weight on the airway? Does the sleep apnea cause the metabolic syndrome or vice versa?
It's a bidirectional relationship. The typical assumption is that it's purely mechanical, but the hypoxia from OSA is a massive physiological stressor.
Oh, because oxygen saturations are dropping.
Right. Every time the airway collapses, it triggers a profound sympathetic nervous system surge.
Oh, I see. So the resulting spikes in catecholamines and cortisol overnight drive severe acute insulin resistance.
And stimulate further release of pro-inflammatory cytokines.
Wow. So treating the OSA with a CPAP machine actually functions as an insulin sensitizer.
Exactly. By resolving the intermittent hypoxia and blunting that sympathetic drive, a patient's systemic insulin sensitivity improves,
Even in the absence of weight loss.
even without losing a single pound.
That is wild.
Yeah,
And we also cannot overlook hyperuricemia.
definitely not. The insulin resistance at the level of the kidney causes a specific defect in the proximal tubule.
Right. Hyperinsulinemia upregulates the URI2-1 transporter, which significantly increases the renal tubular reabsorption of uric acid.
And that excess serum uric acid isn't just a gout risk.
No, it directly impairs endothelial nitric oxide synthase in the macula densa,
And that lack of nitric oxide impairs vasodilation.
triggering the activation of the RAAS system, the renin-angiotensin-aldosterone system, which cements the hypertension we see in the 3 out of 5 diagnostic criteria.
So when synthesizing all of this into a clinical vignette, you have to look for the overlapping presentations.
So like if you see a female patient with daytime somnolence, oligoovulation, and elevated hepatic transaminases.
You are looking at the holy trinity of metabolic syndrome comorbidities:
Right.
OSA, PCOS, and MAFLD.
Boom! That is how you crush the boards. But we know how to diagnose it. We know the comorbidities. So what does this all mean for the prescription pad?
Well, lifestyle modification is foundational, obviously.
Sure, but when that's not enough, we have to target the central adiposity driving the syndrome pharmacologically.
And the most potent pharmacological tools for weight loss currently are the GLP-1 and GIP receptor agonists.
Like liraglutide and semaglutide?
Yes, and the dual agonist tirzepatide. The clinical data in the sources shows tirzepatide achieving up to a 20.9% reduction in body weight at the 15 milligram dose.
20.9%. That rivals bariatric surgery.
It really does. It severely delays gastric emptying and increases central satiety.
But exams often test the contraindications of the older weight loss agents, right? Specifically naltrexone or bupropion.
Oh, absolutely. Bupropion is a norepinephrine dopamine reuptake inhibitor.
And it fundamentally lowers the seizure threshold in the brain.
So prescribing naltrexone or bupropion to any patient with a history of seizure disorders or conditions that predispose them to seizures like anorexia or bulimia is strictly contraindicated.
Massive red flag.
Plus, its dopaminergic and noradrenergic activity can elevate blood pressure. So it's a poor choice for a patient whose metabolic syndrome includes uncontrolled hypertension anyway.
Okay, so moving from weight loss to dyslipidemia, statins remain the first-line therapy to lower LDL, right?
Yes, to provide proven cardiovascular risk reduction.
But if a patient's fasting triglycerides return at like 550 milligrams per deciliter, the immediate clinical priority shifts.
It shifts to preventing acute pancreatitis.
Right. At that threshold, you must initiate a fibrate to rapidly clear the triglycerides via upregulation of lipoprotein lipase.
But this sets up one of the most critical pharmacological interactions in medicine.
Because a patient with metabolic syndrome often requires both a statin for their LDL and a fibrate for their triglycerides.
And combining a statin with gemfibrozil is a massive error.
Huge mistake. Gemfibrozil actively inhibits the OATP1B1 transporter in the liver, which is required for statin uptake.
It also competes for the exact same glucuronidation pathways used to metabolize the statin,
So the result is a massive spike in statin plasma concentrations.
carrying a severe risk of statin-induced myopathy and life-threatening rhabdomyolysis.
So don't get tricked. If you must use combination therapy, the correct physiological choice is fenofibrate.
Yes, because fenofibrate does not interfere with statin glucuronidation.
Good to know. We also have to address the extreme end of the lipid spectrum. Homozygous familial hypercholesterolemia, or SOH,
These are genetic mutations where the LDL receptors are essentially absent.
meaning standard statins are basically useless.
Right. The sources detail orphan drugs like lomidopide and mipomersen for these cases.
Lomidopide acts by directly inhibiting the microsomal triglyceride transfer protein, or MTP, in the endoplasmic reticulum of hepatocytes.
And mipomersen is an antisense oligonucleotide that binds to the mRNA for apolipoprotein B100, preventing its translation.
So both mechanisms basically block the liver from assembling and secreting VLDL particles.
Yes. But think about it. If the liver is unable to package and export the lipids it's processing, those lipids have nowhere to go.
They become trapped.
Exactly. This creates a direct, mechanistically predictable adverse effect. Both lamidopide and mipomersen cause severe hepatic steatosis.
Oh, wow. So you are essentially inducing an iatrogenic fatty liver just to lower the circulating LDL.
It's a drastic measure for drastic disease.
That brings us to the ultimate trap regarding the HDL criterion. Since low HDL is one of our 3 out of 5 criteria, why wouldn't we just hammer the patient with nicotinic acid to raise it?
Because it is a total red herring. Nicotinic acid, or niacin, can raise HDL by up to 30%.
By decreasing the fractional clearance of ApoA.
Right, so it looks like a perfect solution on a lab panel. But major clinical outcome trials, specifically AIM-HIH and HPS2-TH-RIVE, definitively prove that raising HDL pharmacologically with niacin does not translate into any reduction in cardiovascular events.
Wow, so you fix the biomarker, but you do not alter the disease course.
Worse than that, it actually exacerbates the underlying pathology.
Really? How?
Niacin has a well-documented side effect of worsening insulin resistance. It drives up fasting glucose level.
Oh, geez. Likely through a rebound increase in free fatty acid mobilization, right? Or direct interference with insulin signaling.
Exactly. So prescribing niacin to a patient with metabolic syndrome literally accelerates their progression toward type 2 diabetes.
All for the sake of an HDL number that offers no cardiovascular protection.
You simply do not use it for this indication.
Incredible. So to quickly recap the high-yield takeaways for you guys listening, the board exams demand that you synthesize this entire cellular landscape. You're not just memorizing the 3 out of 5 criteria.
But we're tracking how the massive FFA flux from the visceral toxic factory jams the IRS-1 signaling cascade in muscle.
You are visualizing the shift from adiponectin to TNF-alpha, the suppression of SHBG driving PCOS, and the URAT1 upregulation cementing hypertension.
When you understand the mechanism, like why gemfibrozil competes for glucuronidation or why blocking ApoB causes hepatic steatosis, the clinical vignette becomes a roadmap rather than a guessing game.
It all just makes sense. But to push the boundaries of this pathophysiology just a little bit further, the sources point to an emerging etiologic driver, one that occurs entirely outside the human genome.
Oh yes, the gut microbiome.
Right. We have tracked the pathology from the visceral adipocyte, but research actually indicates the inciting trigger might originate in the intestinal lumen.
Specifically, an altered ratio of firmicutes to bacteroid species in the gut is heavily implicated in the development of metabolic syndrome.
This specific dysbiosis alters bile acid metabolism and changes the production profile of short-chain fatty acids.
And this microbial shift increases intestinal permeability, which allows lipopolysaccharides to enter the portal circulation.
Directly triggering the hepatic inflammation and systemic cytokine storm we've been discussing this whole time.
It really shifts the entire paradigm. It means the profound insulin resistance and the resulting cascade might be engineered by microbial metabolism before the human cells even get involved.
So next time you are dissecting a complex metabolic vignette, remember the invisible mechanisms operating at the molecular and microbial level. Could the future of board exams involve prescribing customized bacterial cocktails? Something to ponder. Good luck on your exams, trust your understanding of the physiology, and we will see you on the next deep dive.